another episode of the AI Healthcare Podcast. I'm your host, Dylan Reed, and today we are joined with my friend, Dr. Karen Seagraves, who's a senior healthcare executive and consultant, an AI startup advisor, and is also a former enterprise vice president. Thank you so much again for your time today, Karen.
Well, thank you for having me. I'm looking forward to this.
Same here. And what got you into AI healthcare?
I actually had the great fortune of stumbling into AI when I was an administrator in a healthcare system in Atlanta, Georgia. And we were doing research, and the research was utilizing some new types of artificial intelligence in radiology. And it absolutely opened my eyes to the possibilities of improving patient outcomes using AI.
Awesome. And you said Atlanta, and the Braves are playing today, right?
Oh, why, yes, they are. And probably while you and I are talking, we will clinch a wild card berth. So I might get very excited in the middle of this call.
No worries. Totally understand. I'm a big baseball fan myself, so I totally understand. And being a consultant, what common themes and stories do you see in each of the companies that you work with?
It's interesting. I made sure as I moved into the space of consulting to only work with companies that I felt were providing value for patients and their families, but also for the people who take care of them. So that was my one ground rule: was if I'm going to take on this company and work with them, I have to really believe in what they're doing, and believe that it has the potential to be beneficial or valuable or, improve clinical outcomes. So the common theme among all of the companies I work with is that they're doing something in the space that's either novel or very, very needed and not currently happening in any type of lucrative way. And so I would say they're all within the span of healthcare. One of the companies I work with is fintech, but it's helping the providers and those who take care of the patients. So that would be a common thread across all of them.
And so when you work with companies, is it more, would you say more like, is there actually a business opportunity here? Is it more like a moral, ethical? Because, you coming from the nursing side, I'm very kind of curious from your perspective. Yeah. Is there do you kind of have like a Karen checklist that you're like, they have to hit X, Y, and Z before you even work with them?
Well, they really do.
Okay.
That's a great question. So in order for me to work with a company, first of all, I put my nursing hat on. And sometimes that's difficult because some things are in sort of outside of the scope of nursing practice. But I put my hat on and say, first of all, is this something I would use? Is this something I would find practical in the healthcare space? I also put on my administrator hat. So I spent many years first as an executive director of a system in Atlanta, and then I also moved into a larger role in Charlotte, North Carolina, having responsibility for inpatient and for outpatient and for imaging and diagnostics and neurovascular lab. And I say to myself, is this something that could provide value in a number of different ways? So obviously patient outcomes, that's always first. It's why we do healthcare and not, any other industry. But second of all, from a financial perspective, what's the return on investment going to be? After the pandemic, we were really looking at cost avoidance as well. So it was sort of a different way of looking at profitability. And then I look at, is it safe? Is it secure? Is it something that is going to keep the information about my patients? And is this data going to be used only for my healthcare system and to benefit those we care for? Versus is someone farming my data and taking it away and going to use it for, I won't say evil, but going to use it for the good of something else. So there are different ways that I look at it. And then I put my hat on as a researcher and I say, was this information gathered to develop this in a way that was unbiased? Is it a way that considers diversity? Is it something that looks at equity in how people were involved in the collection of the data or involved in enrollment in the clinical research? So I really look at it from that. So different hats that I wear in that space. And then as a consultant, I have to look at it from a practicality standpoint. Is there a need in the market for this? Is there a place for this particular solution? Is it redundant? Is it something that's been done 1,000 times already? Is it something that we feel could really move the needle and really change how we do things? And is it transformative, or is it just one more thing that people are going to be expected to do, and then it's going to be sort of either met by using sort of a backdoor into just meeting whatever new requirement there is because of it? Or is it something that's really going to become part of a workflow that is useful and practical and achieves what we think it will from the business perspective? So I have a lot of different ways I look at something when I'm
Yeah.
considering.
No, and you bring up an interesting point because it's very similar, kind of the battle in the public policy space. It's how do you improve patient outcomes, but also at the same time decrease federal spending? So it seems like that there's a lot of, even though they are separate lanes, the public policy space and the business space, they kind of, you really have to have an understanding of one to really be able to be successful at the other, and vice versa nowadays.
Absolutely. And you bring something up that's really important in the policy arena. You've got federal, but you also
Hmm.
have state by state by state, including in some states, you have different regions or different counties that are governed by different policies and different legislation. An example of that would be in the world of stroke, which is my specialty. When we are looking at stroke programs and routing of ambulances, right? So if you call 911 and an ambulance picks you up, where they take you could be governed by um, the level of disability you're displaying from the stroke. So whether they take you to a comprehensive center or whether they take you to the closest stroke center or whether they take you to hospital is all governed by the legislation where you live. And in some places it's where you ask them to take you, if you're able to communicate that. So we have to take all of those things into consideration when we develop some type of solution and try to say that this is something that we can commercialize widely in the United States.
Hmm. And kind of being from the nursing side, what does the integration of AI in healthcare look like to you?
We say AI, that's a great question, because when we think of AI, obviously we think of so many different types. It's not just, it's a blanket term that covers anything from natural language processing, different types of machine learning and deep learning, to what you think about as generative AI. I know people using it daily in the space when they're trying to write white papers, and I know it's being used widely in the radiology world to help determine and expedite reading of those most crucial or critical diagnoses. Right? Some people are using it for things like route patients. So talk about AI in nursing, there are a number of different ways it's being used. And so AI can be used from anything from scheduling. So I think about it when you look at the acuity of a patient and understanding what's a safe nurse patient ratio and how can we use it to decide how we design the schedule, or documentation, charting. We use it a lot in healthcare for being able to capture important information and making it a part of the electronic health record and trying to make people's lives easier. Another way to look at it is in billing and coding. And a lot of nurses are employed to comb through electronic health records and try to see if things are documented appropriately to demonstrate the comorbidities of a patient, in order to sort of say, when we bill for something, we can recover more revenue if we truly capture how sick a patient is. So lots of different ways it can be used when we talk about AI in nursing. I think recently we've seen in the news where nurses are protesting AI, some of them from a perspective of, is it what's the right thing for the patient? We want to make sure that we are individualizing our care and making sure that we are approaching our patients from a human side and a caring side, and that artificial intelligence isn't going to take this away. And I'll give you an example. Have you been on a website lately where you're trying to schedule something or receive care and you have a chat bot and the chat bot is asking you questions and you know it's not a real person, but it's trying to be, and it's taking away that element of humanity and caring, whereas at the same time, some people find extreme as patients value in the chatbot because it helps you cut to the chase and get the care you really need or give you the information immediately that you're looking for. So again, as a nurse, I think the primary approach that I take is, are we using it in a way that's going to advance clinical care, that's going to
Hmm.
take into consideration evidence-based practice and clinical guidelines? And are people going to receive the care in the timely fashion that their clinical need dictates? And am I taking work away from nursing at the bedside, for example, in an acute care setting, so that they're not having to do duplicative work and document in multiple places or use multiple systems, communication applications in 2, 3, 4, 5 different ways, so that they're communicating with one group this way, another group that way, and then really they're spending all of their time doing that work away from the bedside of the patient.
Mhm. And you bring up an
So those are all my
interesting point
nursing hacks.
about, wow. No, it's I don't, and it's amazing to me. I don't know how nurses do it day in and day out, and I have mad respect for the profession. But it's, and it's amazing because you mentioned in our previously in the conversation North Carolina and also Georgia, um, two universities that have really taken the mantle, specifically in the South, which, that could be a longer conversation for later about how I think the South is the next hub for AI healthcare innovation, but don't want to gear the
Mhm.
conversation too much towards that direction, is Emory and Duke are starting to
Mhm.
become really big players in the AI healthcare space.
Absolutely. And I had the great fortune with working with a number of the providers from Emory University School of Medicine who were faculty at Grady Health System in Atlanta, where I spent 8.5 years. And it was incredibly exciting time to be in that space. We really look as providers of clinical care to make sure our patients have the best possible chance for a good outcome. But at the same time, it's really the responsibility of institutions in the academic world to find ways to change how we care for patients globally. And the research that we do requires huge volumes of information and the ability to enroll patients in clinical trials so that we can find the next best way to take care of people. And I think the mindset and the culture of an organization is what lends itself to being open to doing this type of work. And I think when we fear AI and we try to regulate AI so much so that it takes away the creativity, we're really hurting ourselves because one of the things I've learned in healthcare is that we can't just do things because we've always done them that way. And so I think you're right. I think that there are a number of centers around the country that are being developed to try to be incubators for AI. And the Southeast, I think we're a sleeper. I think we've been doing it for a long time. It's only just becoming more widely known. Having grown up in the Northeast myself and then moved to Atlanta when I was 17, I recall having a mindset that we really were the center of the universe. And I think the more we consider that the brain power around our country
Mm,
is not just focused in one particular region, the more we will recognize that we have an untapped gold mine of creative thinking and
mm,
technical thinking that is going to really help us advance AI, um, not just nationally, but globally, and coming from places, like you said, the Southeast as well.
mm. And you know, to kind of change gears in conversation a little bit,
Mhm.
so from, and I'm curious because I was never a nurse. So like, how was nursing, specifically patient care, done pre-AI from your experience?
Well, I can give some great examples. When I was a bedside nurse, early on, we
Mhm.
did not use an electronic health record. We wrote in the chart, and we had paper, and we had notes, and our medications were listed in sort of this system where you every shift had to reconcile your medications and make sure that everything was correct, that they were still on those medications, what the doses were, what the frequency, and it was all given on paper. The second big difference was that when we gave report, and I'll never forget my very first job, the way we gave handoff communication, which, by the way, the number one place where errors happen in healthcare is in handoff from one level or one person to the next. We used to use a cassette recorder, and we would record our report for each of our patients. And when I was at the bedside, when we started, we had on average about 6 patients per shift, and that was on days. And then the next nurse would come in and they would listen to your recordings of your reports. Now, unfortunately, not allowing for bedside handoff did not allow for that validation, I see, you see, we see, which is so incredibly important, or that warm handoff. This is the person who's going to be caring for you next. But if the tape didn't work, or if you had questions about what was in the report, that nurse was long gone. They were halfway home. And by the way, we didn't all have cell phones yet. So you were really in trouble. And I can't tell you how many times I walked into a room and the patient I was seeing and the exam I was doing looked absolutely nothing like the report I heard on the tape recorder. So that being said, I know I sound like I'm coming from the dark ages, but this was not that long ago. So there was no opportunity for AI, but I'll tell you something else that we had to do. In our documentation, we manually acutize the patient. And we arbitrarily, for whatever reason, I don't know, the numbers were either a 7 or a 14 or a 21, and how you assigned values to the different tasks and how critical the patient was. So I'll give you an example. If a patient had sequential compression devices to prevent VTE, and those were the little pumps at the foot of the bed and the little things that inflate and deflate on your lower legs when you're in the hospital, that was a 7, right? Because it was something you had to make sure they were on, make sure they were working, take them on and off when you had to get a patient out of bed, right? So you took that into consideration. If a patient had IV antibiotics, so you would have to make sure that you had a good IV access, you were flushing the line, that you had a pump available, that you were setting the pump. So it really tied to the amount of time that you were going to have to spend in a patient room. And that way, if you knew how much time, you could theoretically say, well, this nurse should only have 4 patients because this person has to be turned every 2 hours and they need a team to come in there and turn the patient to prevent any kind of skin breakdown. So it was all manual. And by the
Wow.
way, that kind of went out the window when you just didn't have another nurse to come in to take care of the patient, right? So if you had a high acuity, but you didn't have a person coming in, and now let's flip AI and nursing, there are extraordinary, like just ways where you can not just determine the acuity of a patient, but flex staffing and the ability to look at an entire hospital at once, how many people they have coming in on that shift in every area, the training of the nursing to know if they're med surg or immediate, intermediate care or acute care or critical care, so that you can flex people around the hospital, but also have that flexibility to bring in nurses on the spot to cover shifts. And all of that is being done with algorithms that are built using AI. Night
Wow.
and day, night and day.
So I mean, like, so I mean, I might be like asking a silly question, but it's like, what happens if, like, were there instances where people like just forgot to leave the cassette tape for the next nurse, or like someone lost the cassette
Oh, yeah.
tape?
There were lots. And remember, you used the same tapes over and over again and recorded over them. It wasn't like there was a new tape every day. So, and then
Oh,
there were
okay.
other, we moved to a system at one point where you were recording it. So just like you think of a dictation line, we recorded our part over the telephone. So you'd kind of call into a number and you'd leave your report. And then when you came on shift, you would call into a number and get your report. And so you just did it through a telecommunication system. So it got rid of the old tape recorders, but it was still the same concept, right? There wasn't somebody there to ask the questions. There weren't two people laying eyes on the patient. And you certainly didn't have the opportunity to walk into a room and say, it looks like that didn't infuse. Were they supposed to get that dose of that particular medication? Or for someone to say, oh, no, we held that because. So by not having that in-person communication, you really lost that interoperability. So I would say we've come quite a long way. Now, where we haven't is that we haven't really delivered on the promise of the electronic health record. And some of the work that I do in consulting is really looking at how can we better leverage the information that's embedded in that electronic health record so that we're providing the best possible care based on the individual patient. And I think you actually talked a lot about that on another podcast recently, but for a nurse, we want actionable information and we want access to that information. So let's say there's been a change in what the requirements for blood pressure management are going to be based on the patient's clinical condition. We want to know right away, have those targets shifted? What are we taking into consideration? When would we use one medication versus another? Because perhaps that blood pressure agent isn't the best one because their heart rate is too low, right? So lots of different pieces. And we want that at our fingertips to provide optimal care. And AI can do that.
And so, so my next question is, how would you like to contribute to the greater AI health conversation? Not just as, from your nursing background, not just as a consultant, but you, Dr. Karen Seagraves.
Well, I really look at everything I've been able to experience in my career, and I have spent, dare I say, over 30 years in healthcare at this point. Not to mention in that time, I've been a patient.
I'm almost
And
that
I've been
age.
a family member, and I've been a loved one. I've been a loved one, a caregiver. And when I look at that, I recognize that if I can provide any value that is going to prevent complication, that is going to enhance communication,
Mhm.
that is going to optimize efficiency. And why is it important to optimize efficiency? Because we have a lot of people who need care and we don't have enough people to provide it, right?
Uh-huh.
If we are going to be able to be the best possible healthcare system for people to be healthy, and health is not just physical, right? But to be healthy, to prevent illness, to treat acute illness, secondary prevention, and quality of life, that is where I aim to provide value. And if I can do that through the experiences I've had as a clinician, as a researcher, as an administrator, and as an advisor, and even as a key opinion leader, then I'm going to keep working at it. And that's what I aim to do. That is what I offer. And that's where I think we don't spend enough time listening to the people who've actually done it and the people who are in it every day to say, we need this and we don't need that.
Mhm. Well, and so you bring up another interesting point. So, I'm almost 30 years old, so I'm not afraid to mention my age. But I don't remember growing up there being like nurse strikes left and right. Is that a fairly recent phenomenon post COVID?
As long as there have been unions, there have been strikes. Now, not every state in the US has nursing unions. So it's very interesting as I travel around the country reviewing hospital programs. I've come right through picketing nurses, and then I've been lots of places that unions don't exist. So I think it's always been there. I think social media and access to information so widely have shared a lot of that. I think the pandemic brought that to the forefront, and you might have seen a lot more of it in terms of nurse-patient ratios, wages, and safety, especially with employee workplace violence.
Yeah.
We've seen a lot of that front and center. Has it been there before all of that? Yes. Is it widely represented enough in the United States? Again, it's state by state. And in some states, they've been able to make great enhancements for quality of life and patient safety through union organization to affect things like nurse-patient ratios. But it's been there.
Okay. Yeah. No, that's helpful background information. Yeah, because it seems like you hear about a nurse strike like every week for some now, it seems. And now it makes sense because it's just the shortage of nurses. And then it's like when you have a shortage of nurses, but then a larger patient ratio, then that tends to lead to disaster right there.
Mhm. Well, and also a lot of documentation requirements. When we know we have a saying in nursing, if it's not documented, it's not done. And in a society where people are always looking to poke holes or to come back and say we didn't do something the way we should have, it almost becomes like you're documenting to defend yourself. And that's not what it should be. Documenting should be, how do we communicate with the next person who's going to care for this patient so that they can have seamless and safe care? And I think a lot of it, with that burden of documentation and that expectation of providing care, and using all of these various and wonderful, glorious tools we've invented to try to make workflow better, I think that nurses are saying, wait a minute, we're putting our foot down and we're standing up for our rights because we were trained to care for people. And caring implicitly involves, being at the bedside and taking the time with our patients. And we want that time back. I think that's
Mhm,
where you're seeing it.
mhm. No, that's helpful. And that leads into my next question nicely. So, what do policymakers need to understand when constructing future policies to better integrate AI into healthcare as well as the nursing field?
I think what they need to do is take into consideration who they're legislating for. Very
Mhm,
often, legislation is to protect entities like large healthcare systems or government hospitals, and everyone's trying to protect themselves from things like data breaches or hackers. And I think it puts a bad taste in people's mouths around AI. I think what they need to be considering is, can a patient, for example, an example from radiology, can a patient who has AI applied to their clinical imaging of their brain quickly get identified as someone who needs to transfer to a higher level of care to save their life and give them a better outcome? And should we have access to that technology so that we can do better for our communities and for their health, and do better with the resources that we have and the scarce resources by keeping people in their communities who don't need to transfer because we have more information? So if I could look at a legislator and show them the clinical examples, and then at the same time also the quality of life for the people providing the care, right?
mhm,
If I can understand how to manage a patient because I have access to information in a way that's useful and protects patients from us missing important things, then that far outweighs the risks that we're talking about by using AI. At the same time, one more very important component is, as a legislator, I always want you to ask the questions. How was this AI algorithm trained? Was it trained in a diverse population? Was it trained in a population that included men and women, that included people of all ages, of all races, from different parts of the socio economic demographic? Because when you train an algorithm and then you make clinical decisions using that algorithm, if it wasn't trained on a diverse population, then you may actually be hurting a patient because you're doing something that was intended for, 65-year-old Caucasian males that were used to
mhm,
train an algorithm only. So it's incredibly important that we look at the integrity of the algorithms and not just use that blanket term and say AI.
Mhm. So you're kind of looking at it like what would work for like a Charlotte or like the Piedmont Triad area in North Carolina is not necessarily going to work for a small town in Western North Carolina from an AI healthcare standpoint.
Well, that's getting really specific because I think anybody can live anywhere, right?
Uh-huh.
But what I'm really looking at is if I'm going to make clinical decisions to treat
Mhm.
a patient, I want to make sure that those decisions were built off of information that was gathered from a wide variety of patients and not
Mhm.
just a small subset. Does that make
Okay.
sense?
Yes. Now I'm starting to because the reason why I asked that is from like a logistical standpoint, like could you foresee that that might be a little challenging to get the data from multiple sects of the population into an algorithm so that it's trained properly?
We have to ensure that we are doing research in those diverse spaces for that exact reason, right? We cannot build algorithms that are based off a small subset, or we can only say this is only applicable in this particular demographic. So when we are building
Mhm.
AI, we've got to take into consideration that if we want it to be widely applicable,
Mhm.
then all parties need to be represented in the development of the solution.
Awesome. And Karen, where can people find out more about you? And the work that you do.
Well, you can always go to my LinkedIn, and it's Karen B Seagraves, which is pretty easy to find. Just use the middle initial because there are other Karen Seagraves out there. And eh, really, I've published a good bit, so you can look for me in that space.
Mhm.
Um, if you just hit your Google. You can
Hit
read
your
some of my work. Recently published as a vice chair of the writing group, A Scientific Statement with the American Heart Association. I also work as a managing editor of a clinical journal called Stroke Clinician. So you can find me in all of those spaces.
Awesome. And be sure to subscribe to the YouTube channel of the AI Healthcare Podcast, as well as listen to the audio version of this interview on Spotify and Apple Podcasts. Karen, thank you so much for your time today. I really appreciate it.
It is a pleasure and happy to share information about AI anytime.
Awesome. And this is Dylan Reed signing off.